Good evening, everyone. It is an honor for me to talk in this panel as a nephrologist after Dr. Bipin Sethi and Dr. Sastry about the same drug, how a nephrologist will look at it in his day-to-day practice. The metabolo-diuretic promise or Dapagliflozin or in general the SGLT2 inhibitors in practice of nephrology in the context of heart failure and kidney disease. This drug as a class is considered to be a drug which I had put a lot of excitement in the minds of nephrologists because this has emerged as one of the most exciting drug in the current day practice of nephrology, which is going to make a big difference in the outcome so far the kidney disease is concerned and the complications of kidney disease like the cardiovascular outcomes. So in this context, what I would like to highlight is that US FDA has fast-tracked this drug, Dapagliflozin in CKD patients with or without type 2 diabetes to slow down the kidney disease progression and reduce the cardiovascular risk, which is going to be discussed in the subsequent slide. Why it has been fast-tracked. We all know that the kidney and heart interacts in a very complex and bidirectional manner with or without diabetes. And it has been reported that the risk of patients who develop chronic kidney disease, particularly with diabetes, is so high that most of the patients die before reaching the end-stage renal failure requiring dialysis because of the cardiovascular events. And hence, it is very important for us to look at this pathophysiological derangements in the patient of chronic kidney disease, and how we can address it with the evolving kind of therapies which is emerging, particularly the use of SGLT2 inhibitor. Does it make a difference? So the presentation will have certain important points to highlight that the cardiorenal interaction of this drug, particularly in a patient who is diabetic or even not diabetic with a low GFR. So we know that the heart and kidney interacts in a very complex and bidirectional manner. There are certain factors in a patient who has cardiorenal syndrome which impacts the disease progression bidirectionally, which is grouped under the two broad pathophysiological mechanisms: the hemorrhagic mechanism of fluid overload, the renal and cardiac congestion, which interacts with each other to make more damage, reduced perfusion because of reduced cardiac output, and the vasoconstriction in different organs producing a kind of ischemic injury. The neurohormonal mechanism, particularly the two broad categories, are the activation of renin-angiotensin system in a patient of cardiorenal derangement, that is cardiac disease as well as renal disease, and the activation of sympathetic nervous system because of various pathophysiological events. And these are the two important targets in the therapy of a cardiorenal disease. The patient of chronic kidney disease have a third category of special factors which are operative because which are listed in the third category as chronic inflammation, malnutrition, cachexia and wasting, bone and mineral disorders, that is involves the calcium, phosphorus, PTH metabolism, the acid-base metabolic disorders which ultimately is associated with sarcopenia and malnutrition, and anemia and cardiorenal connection, because anemia is also one of the modifiable factors to treat the cardiorenal pathophysiological events which leads to increased cardiac mortality. So there are three kind of broad targets when a person is having both cardiac disease and heart disease with or without diabetes: the hemodynamic factors, the neurohormonal factors, and the uremic factors, which is to be addressed by the drugs which we prescribe to take care of such patients. So in this context, this is a very important slide which highlights why the Dapagliflozin has been approved by US FDA. Dapagliflozin is the only US FDA approved SGLT2 inhibitor for patients with heart failure with reduced ejection fraction to reduce the cardiovascular death and hospitalization from heart failure, as was discussed by our previous speaker. In the context of kidney disease, this drug has been given a breakthrough therapy designation. There is a special kind of abbreviation, BTD, that is the breakthrough therapy designation for DAPA has been granted by the US FDA based on the CKD trials that we are going to discuss, which has shown an unprecedented reduction in the risk of kidney failure as well as the cardiovascular and renal death in a patient of cardiovascular disease and kidney disease. And hence, this drug has been given this nickname of in the current 2020 as a drug of BTD category, a breakthrough therapy for patients of chronic kidney disease. And even the Indian drug controller general DCGI has approved this drug particularly for treating heart failure with reduced ejection fraction, and we are sure that in the coming years this will also get approved for treating patients with chronic kidney disease based on the KDIGO recommendation which is already there. So if we look at what is so special or spectacular about this drug SGLT2 inhibitor as a class in a patient of chronic kidney disease with cardiovascular disease and diabetes, this cartoon shows that in the glomerulus, the anatomy is such that it has a slightly an afferent arteriolar kind of dilatation compared to efferent arteriolar diameter. So if you look at a normal kind of glomerulus, you'll find that afferent arteriole is slightly more wider than the efferent arteriole so as to maintain an interglomerular pressure for filtration. But when the person is diabetic, there is a marked afferent arteriole dilatation or vasodilation which increases the interglomerular pressure, which has a downstream kind of events of increase in proteinuria and subsequent kind of inflammatory injury which happens. So when we are using the drug SGLT2 inhibitor in a simple way, we can say that it slightly reduces the afferent arterial diameter, that is, it produces afferent arterial constriction, and thereby it reduces the interglomerular pressure. And this reduction of interglomerular pressure is because of tubuloglomerular feedback, that is, the tubule at the level of distal tubule of macula densa sends a kind of signal to the afferent arteriole to constrict, and that is happening through a kind of a kind of chemical which is adenosine. So this is a simplistic way to say how this drug is renoprotective. Normally in a diabetic state with chronic kidney disease and with a progressive disease, there is an increased interglomerular pressure because of afferent arterial dilatation to a higher extent, which is taken care by the SGLT2 inhibitor and that is how it is theorized to produce a benefit in kidney disease progression. So in this context of the renal protection, Dapagliflozin has been used as a drug in 3 important landmark trials based on which the drug is going to be prescribed even by the nephrologist to take care of such patients. DAPA-CKD trial, the DERIVE trial, and the DELIGHT trial are 3 important trials which are randomized trials, prospective trials, which have looked at the benefit of Dapagliflozin in a patient of chronic kidney disease. One of the most important trial, the DAPA-CKD trial, which is going to form the basis of recommendation by different kind of organizations, is the DAPA-CKD trial. It was a trial which was similar to the Credence trial, which was where the canagliflozin was used for diabetic patients. But this trial has included patients which are diabetic and non-diabetic both. The key inclusion criteria were similar, that is more than 18 years of age with a GFR in the range of 25 to 75 ml at the time of inclusion. The patient should have a proteinuria of urine albumin creatinine ratio of 200 to 5000 milligram per gram and should be on the maximum tolerated dose of the standard drug ACE inhibitor ARB for at least 4 weeks if not contraindicated. The exclusion criteria was the patient should not have type 1 diabetes, polycystic kidney disease, lupus nephritis, or any form of ANCA-associated vasculitis, and should not have received immunosuppression in the last 6 months. So this patient had included both diabetic patients and non-diabetic patients, and this was a multicentric study. More than 4,000 patients were included, and the follow-up duration was of 2.4 years. So this was a kind of randomized placebo-controlled trial. The usual way the randomization was done. The one arm had received dapagliflozin 10 mg once daily, and other arm was having a matching placebo in the follow-up, and then it was analyzed in the follow-up what happened, etc. So what is shown in this slide is how the placebo group matched the dapagliflozin. You will find that all the parameters were matching. There was no kind of difference between the placebo group and dapagliflozin group. There were almost 68% of patients in the dapagliflozin group who were diabetics and 67% in the placebo. The remaining were non-diabetic patients. The blood pressure in the appropriate range. And the eGFR for both the groups were, the mean eGFR was 43 ml per minute, and 97% of patients in both the groups were on ACE or ARB. So that is to say that both the groups were matching so far the demographics were concerned. And this was a kind of trial which included white, black, Asian, and others. 35% of the population in this study was the Asian group. So it is applicable to our patient as well. So this trial examined the effect of SGLT2 inhibitor in patients who were having chronic kidney disease. And in this trial, 32% of patients didn't have diabetes. And about 15% of patients had a GFR below 30 ml per minute. That means the patient were having a CKD beyond stage 3 also. Few patients, 15% of patients were in stage 4 kidney disease. So this was a very important kind of inclusion criteria to see whether the patients who were non-diabetics and who were having advanced kidney disease got benefited with the use of this drug. So what was the result so far this trial was concerned is shown in the slide. The primary endpoint and the secondary endpoint of this trial was met. And there was a kind of statistically significant difference between the Dapagliflozin group and the placebo group so far the primary and secondary endpoints were concerned. The primary endpoint for this trial was sustained reduction of GFR more than 50, decline and development of end-stage kidney disease or renal and cardiovascular death. While the secondary endpoint was only limited to kidney disease. So whichever way we see the benefit of dapagliflozin, it was seen that the patient benefited. Both from the kidney standpoint as well as from the cardiac standpoint, and this was a very statistically significant difference. So it was concluded based on this trial that dapagliflozin patients with chronic kidney disease, if they are prescribed, whether they have diabetes or they do not have type 2 diabetes, it reduced the risk of kidney failure compared to placebo. It reduced the risk of death either because of cardiovascular cause or hospitalization for heart failure, whether they're diabetic or non-diabetic, and it prolonged survival, both the renal survival and the ultimate survival because of lesser incidence of heart failure and heart events. So dapagliflozin was also reported to be well tolerated in keeping with the established safety profile, and there was no difference so far safety issues were concerned between the DAPA group and the placebo group. So this was a very important kind of conclusion from this DAPA-CKD trial, that this drug is not only cardioprotective but also renoprotective even in absence of diabetes. Another trial to support this concept was already done in the past, the DERIVE study, where the efficacy and safety of dapagliflozin in patients with type 2 diabetes with a moderate renal impairment was analyzed. By the term moderate renal impairment, they meant that the GFR was between 60 to 45 ml per minute. And this was the older study, it was done in 2018. And what was found out in this study is shown in the subsequent slide, that when this drug dapagliflozin was used in a patient who had a GFR between 60 to 45 ml and were followed up for 6 months, as expected, the dapagliflozin had some kind of decline in the GFR, because we know that the dapagliflozin is a drug which reduces the intraglomerular pressure, and it is known to have some decline in the GFR, which is ultimately in the follow-up gets normalized. That was seen that by 6 months time, the dapagliflozin group had a GFR which was coming close to the placebo arm. That is to say that there was no kind of reduction of the kidney function in the follow-up, and this drug was safe at 6 months in the earlier reports of 2018 when it was used over and above the ACE or ARB. And it was reported that when you are using this drug, when the GFR is between 60 and 45 ml, compared to placebo, there was a kind of statistically important reduction of hemoglobin A1C, the fasting plasma glucose, systolic blood pressure, and the body weight compared to placebo arm. That is to say that it was effective at that GFR so far diabetes was concerned, besides the other kinds of pleiotropic benefits that we know is associated with the use of SGLT2 inhibitor in general. So this was the conclusion of this trial that in patients with type 2 diabetes with CKD stage 3A, dapagliflozin 10 mg compared to placebo significantly improved the glycemic control, the body weight, and the systolic blood pressure. The safety profile was consistent with the established profile of dapagliflozin in general in type 2 diabetic population, as was discussed by our previous speaker, that DECLARE TB trial. There are no adverse event of bone fractures, amputation, or TKA was reported in this trial. This DERIVE study demonstrates that dapagliflozin has a good safety profile and is effective in reducing hemoglobin A1C in a stage where it can be used for that purpose. Besides the body weight reduction, blood pressure control when the GFR is between 45 to 59 ml. So that was one of the other trial. The third trial, where this dapagliflozin was used, is the DELIGHT trial, the albuminuria loading effect of dapagliflozin alone or in combination with a DPP-4 inhibitor in type 2 diabetes with chronic kidney disease, a randomized double-blind placebo-controlled trial. In this, about 460 patients with known diabetes who were having albuminuria in the range of 30 to 3,500 were included. And the GFR was again the same range of 25 to 75 ml, with the hemoglobin A1C varying between 7 to 11. And all patients were on stable doses of ACE or ARB before this drug was introduced. And they are on glucose loading treatment for at least 12 weeks before they were included in the study. So what was found in this DELIGHT trial was that patients compared to placebo, whether they used dapagliflozin alone or dapagliflozin with saxagliptin, there was a kind of remarkable kind of reduction of proteinuria with the use of dapagliflozin. With dapagliflozin alone, it was 21% reduction of the proteinuria from the baseline. And when dapagliflozin with saxagliptin was used, it was a reduction of 38%, and it was statistically significant. One has to realize that when you are using a drug, and if the drug is found to have reduction in proteinuria, which is a biomarker for kidney disease progression, this will be a kind of point to say that this drug is going to have a benefit in the follow-up. The proteinuria reduction remains sustained. So that was the thing which was confirmed in this DELIGHT study. What was found in this DELIGHT study was that though the proteinuria was found to be reduced, the body weight and the fasting plasma glucose was not that significantly different compared to the placebo arm. So the ultimate conclusion of this study, the DELIGHT study, was that the dapagliflozin with or without saxagliptin given in addition to angiotensin converting enzyme inhibitor or angiotensin receptor blocker is potentially attractive option to slow the progression of kidney disease in patients with type 2 diabetes and moderate to severe chronic kidney disease, that is GFR till 25 ml. So this was another study which reinforces that there is not only one study which has found the benefit of kidney disease, the worsening with the use of the drug, but other studies have also echoed the same kind of finding. So to say that dapagliflozin is now a drug which is just like kind of drug which has produced a kind of extreme excitement in the nephrological circle. This is just like a drug which has produced Thalca or a Khalbali in the minds of nephrologists, because this is one of the drugs which has now come which can help the patient. And in this new era of metabolic disorder management, we have so many trials which supports the use of dapagliflozin as an important SGLT2 inhibitor with diabetes or without diabetes to take care of the cardiovascular renal outcomes. And the trials are the DECLARE trial, the DAPA-HF trial, DAPA-CKD trial, and the CVD real trials, which have looked at different parameters, but have ultimately concluded that the patients are benefited from the cardiac angle as well as the renal angle, and hence it is a renal as well as cardioprotective drug. So that was all that I wanted to talk about the use of this drug in the context of chronic kidney disease, an important drug which should be a part and parcel of all kinds of patients where we are using it for CKD progression. Back to our coordinator to have this.